No. ¿Cuántos años tiene? Hi. So, hello. Thank you for joining us, and again, it's a pleasure to be with you. I want to give some notifications first. Next week, I think it's very interesting to assist to ESG days in Europe. There's a lot of amazing live endoscopy and also research in the field of endoscopy. So I believe it's a very good opportunity to be there. We will be there doing some lectures for industry and also for societies and or research. Please do not, if you are going, please do not forget to assist at least or research, the last research that we will showing during ESG days in oral presentation and posters. So also I want to say thank you for our sponsors in general. And today we have a nice case. I want to show you. Normally, I has been showing a lot of advanced therapeutic endoscopy, so we do a lot here. But I want to do today a different thing. Just coming back again to the first steps, because we were discussing with my good friend Moen Kashab, and many people need also this kind of evaluation and this kind of explanation. These help fellows, residents, and also people that is using or starting in some kind of procedures, right? We talk about advanced endoscopy, but I believe US is not more advanced endoscopy. I believe there is a kind of advanced endoscopy, but more than all, I believe that the most advanced endoscopy in US is therapeutic for sure. But today I want to show you this case. This is a 76 years woman with a history of jaundice that came to our unit for an evaluation and for ERCP. So we decided to perform a US because they said there is a pancreatic mass in a previous CT scan a few weeks ago, but today I have a lot of things that we need to show you, right? Not just the mass. On US we need to evaluate for sure. I am now in the duodenal part. You can see here I am using a linear US from Pentax Medical. This is the J10UT series with Aloka Itachi 850. So you can see here the mass, right? Yes, and this is very clear. So this patient have the mass, but I also see these, for example, these areas. This is the main bile duct. You see, this is the main bile duct. So I believe an ERCP will be fine in her, and I will take some decisions regarding what I see in my US, right? So let me see. Okay, I think you will see better. Okay, so now you can see here. This is the common bile duct. This is a stone here. Okay, so I am evaluating also this. That is the access by ERCP by traditional way and not by US. For sure, in some cases, okay, I decide to perform a drainage. It is correct that now is very good technique. You can go faster and things can be easier. And I prefer to use a biliary drainage when these patients, for example, came to here because in other centers didn't achieve to perform a ERCP, and when I see in US that there is not more common bile duct, so in those cases I prefer to go to a drainage, direct drainage. But in this case, I believe there is a lot of things that we need to discuss. Why not to do US guided biliary drainage? Why not? This is very important, right? So first, because I believe there is a still common bile duct here, just here, right? So we can achieve to drain by the standard way, that is the RCP. That will be also cheaper. So second is, when I come back a little bit, I want to see the mass. You can see here the mass very well also. So there is an invasion here of the portal vein, okay? So, and second and third, there is ascites. So I believe this patient have not just you see a very big dilation, and you can see here the ascites. So when I see this, when I see ascites, when I see an invasion, right, and I see that this patient for sure have a carcinomatosis now, so the possibilities of survival is less than 3 months, or almost 3 months. And also the situation is that there's a lot of lymph nodes here, so I know that there is carcinomatosis for sure. You can see the main pancreatic duct very dilated. I can see here I'm in the body of the pancreas, okay? So all these things make me reflect how I will do in these kind of cases, okay? So I believe this patient is not more, this is just palliative treatment. And now we need to have a biopsy because, oncologists need the results about this. But I like to evaluate different kind of technology. So I will go faster because I will already do it. You can see here, so the elastography that I did, okay? So we have a strain histogram of 73, and to be honest, when I am in a suspicion of pancreatic cancer, I want to know if this is adenocarcinoma or not. I believe that by clinical aspect, because of the jaundice, the loose weight, very important, and the deterioration of the quality of life and clinical aspect of the patient, for sure this is probably a adenocarcinoma. I know that because of the history, clinical history. But in spite that histogram, you can see here the color of elastography, right? So it's blue, it means it's a hard tissue. However, when I do the compression, the mean is 73, which means that probably it's not so high, it's not so hard. In chronic pancreatitis we can see that. And also when I apply a strain radio, so the strain ratio is low, it's 5.38. So you have a doubt. I have a doubt regarding if this is adenocarcinoma. But also when I perform shear wave technology, that it measured the kilopascal, the elasticity, the real elasticity in an objective wave way, it means it's not so hard. It's 8, the mean of 10 measures that we do it. So in those cases, we need, if you have a doubt, you need to use contrast, okay, to evaluate if this lesion is or not adenocarcinoma, right? Just to understand a little bit the nature of the case and the patient, right? So we have now a new technology that is called the Dfi. I will apply now Dfi. It will show you if this lesion is or not, or is not, have vascularization, microvascularization. That is very important because tumors are difficult sometimes, right? So you can see I cannot see anything, any vessel. Okay, I can't see any vessel. I see just peripheral vessels. So this make me think that probably this lesion is pancreatic adenocarcinoma. You can see this is the area here. I can see here, I see vessels in this area, in this area, in this area, but not inside. So I believe this is probably an adenocarcinoma. So now I will show you just the biopsy technique, FMB, and I will use a FMB needle. ¿Me das una aguja, por favor? ¿22 está bien? So I will use a 22 gauge needle at Quire from Boston Scientific. And this is very important, okay? The lesion is big, huh? I think the lesion is... ¿Cuánto medía Raquelita? So it's around 3 centimeters by 38, okay? So this is very important. So now I will use a 22 gauge needle. Sometimes I prefer 19 gauge needle, but I believe we will have good result with this one. And also it's very important to try to avoid the vessels. You can see, I see a vessel here. I will show you again. So there is no vessel. So I'm okay. And then I will go inside the lesion. So one of the things that I always say to my fellows is you have a rule here, right? These numbers represents how deep you will go, and if you want to be sure how deep you need to go, you can measure. You see? So 42, so maybe I will put here between 4 and 5 my needle, and then I will pass inside the tumor. So yes, the tumor is not so hard, that's why. And it's not so hard because I believe there is a necrosis. That's why the elastography was not helping us, and the shear wave technology doesn't helping us, and it happens. So that's why we need to use all that we can use, as technology to evaluate the lesion and to talk with your pathologist in case that you have doubts. So now I am taking few passes. I like to, even if I use FMB, I like it to pass many times as possible. Okay, the studies has been showing that with 3 passes is okay, but I prefer to make many passes, good aspiration, and then to put in formalin. Okay. Okay, let's see what we have. Let me see if I can do from the stomach. You see, because we see the lesion here. So you can see there is a very good sample. I don't know if you can see. Puedes traer el teléfono porque yo lo veo borroso. No creo que se vea bien, ¿no? So I will show you the sample that I get. ¿Escuchó Brian? And so we see a sludge here. And I want to see now if there is any, lymph nodes that I can, make also a biopsy, because some people say that it's not important, right? But I believe in this case will be important, because if we have a lymph node from the stomach, for example, so we can at least have the result from the lymph nodes, right? So I want to see very well where I can see it. You see? What I will do is also take an aspiration here, just to send to pathologists. Otra aguja. No, pero no FMI. O dame esa que está ahí. Esa de ahí está bien. So I will now use just this for. You need to use another needle. I like to perform this punction and aspiration because it will help me also for the pathologist to see if my suspicion of carcinomatosis is there. So I believe for the pathologist, for the oncologist, this will be a good more information is much better for them. So now I am making an aspiration, you can see here. And this sample I will send to the pathologist also for make a cytology. This is very important. Because I see like the liver a little atrophic, so maybe it's because of liver cirrhosis, I don't know. I don't understand very well. Maybe it's that. But I believe there is carcinomatosis, so I don't believe that she will, just because of the size of the tumor and all this situation, I believe she doesn't have any chance to make a treatment, right? Curative treatment. This will be just palliative, not surgery. So I take this. Now I finish. So now we are looking. Yes. So can you see the sample? It's a very good sample, and this is that you need to have, to see if this is a good sample or not, right? The tissue is very important when you have that. So I will finish my transmission. Thank you so much. I want to say to you that this year we will not make or congress or presidential congress because we are very tight with time. However, we will be part of Endoscopy on Air Brazil in April, so you can follow us there with some cases, advanced therapeutic cases, and we will have a special edition for the first time, Endoscopy on Air Americas. So we're working together with Endoscopy on Air, my good friend Repici, Alessandro, and also my good friend, the director of this, Mowen Kashab. So we will share just, a standard endoscopy and also, a standard kind of therapeutic, basic therapeutic that I believe will be a nice, very nice to show worldwide and people connected. Okay, so thank you so much again, and see you